It's time to transform ourselves from teacher to become a guru. And very happy Teachers Day to all of you. That is a good timing to start our transformation. And that is the need of the hour today. Amropin welcomes you all. We are thankful to hashtag, our principal sponsors, and our collaborators, Government Medical College Raipur, for giving us this opportunity to start this session. So what we are going to do is curricular restructuring, and the means of how to do that. I am Dr. Bharat Modi, today's presenter. Now there are various things which we will be doing in the curricular restructuring, and this is the list of things which I'll be tackling today. So let us go one by one. Dentistry started somewhere around 1948. Since then, this year has just given us syllabus only, examination pattern, internal assessment, and quota system. Till the 1980s, probably that gave us a good umbrella under which dentistry grew. But slowly it became outdated because we did not develop any curriculum. Curriculum is what to teach, how much to teach, what method to be used, how to know whether student has learned, how we do the monitoring, how is the feedback. All these different steps which are there, these are not incorporated within our framework. And that is why we need to do the changing. The first change we have to do is changing from teaching to learning. Didactic lectures will have to be reduced. Student involvement has to be there. Problem-based learning, discussion-based, flipped classroom, evidence-based, teaching self-evaluation. These are the things which we need to do for various reasons. The first is that we still continue to be doing pedagogy. Even the new education policy which has come also talks of pedagogy. But by the age of 15, the child has already become an adult. And that is why there is a difference between how a child learns and how an adult learns. A child is a dependent learner, so he needs authority. So didactic lectures and all will be good enough for him. But as the child grows on, he becomes an interested learner. And that is why he needs somebody to motivate him to learn. So that is why more about interpretive process is required. Then he becomes an involved learner as he grows up. And that is why he looks at the teacher as a facilitator while he keeps on solving the problem. And the third is, and the last is, he becomes self-directed. As he comes to the PG level, he becomes a self-directed learner. And that is why he needs somebody who will delegate work to him so that he can show how good an expert he has become. So the problem-based learning is something which you require. This change would mean that there should be student-centered learning. Knowles was the first one to have coined the andragogy and pedagogy and explained to us what is the difference. Now, what is the difference in being adult learning? Adults need immediate needs. They don't want to learn something which they may or may not be using it in future. So they want something which is of immediate need. They need life experiences to learn something. So experiential learning is what they're looking for. Active involvement is what they look for. They don't want to passively have a didactic lecture. So self-directed learning is what they are looking for. Relevance-oriented and practical-oriented, that is why transformative learning is what they are looking for. They want respect, they want motivation, they want responsibility, they want dialogue-based, not instructional-based, and they want interactive and not didactic. If you see the age-wise, there is certain amount of difference. I will just concentrate on Generation X and Generation Y. Generation X is what our teachers are, the healthiest and healthiest at present. They want to redefine the traditional values. They are hardworking, passionate, and but they have a sense of hierarchy. So who's the HOD, who's the associate, and who's what. So that they respect. On the other hand, students are generally Generation Y. So they are surfers and scanners. They don't want to read and digest. They expect constant and immediate feedback. Directness, no subtlety for them. Technology savvy, they are very good at technology. And we have to channelize that technology instead of just taking selfies. Always hurried, want to do something fast, and they want to learn. So students have a different expectation, and our teaching learning methodology which is there has to look at what are their expectations. Solid knowledge is real life experience applications. That is what they know. They need everything when in a very and presented. If you are haphazard, they will not respect you. Stimulated active participation is what they are looking for, and they always ask why. Why should I do this? That is, and that answers we have to give them. Faculty needs to be very enthusiastic and involved, and their behavior is as if they are asking for customer services, and that we have to take into consideration when we deal with these students. Only then we can bring them to come out. So student centered education is what we are looking for. The faculty, on the other hand, because of the pressures of the management, pressures of the job and everything, are somehow not coming out as much as possible. So they look at a certain amount of safety period, and they use didactic lectures to pour their knowledge on the student. But the students want active learning, and they are not. So proactive faculty is what we need for tomorrow. Now let us see what is the existing curriculum and what are the pitfalls. Basically, it is syllabus. There is a list of topics which are there. It doesn't tell you how to handle, how many lectures to be taken, how many practicals. It is all quota based. Tasks which are there. Regional differences are not taken into consideration. Behavior, ethical science, competency, depth of knowledge, all these are mentioned but not tackled as a program. So, and a vast syllabus is something which we are teaching where 40% of that is really not known. If you can see, there is just a list of topics which are there. How much of the papilloma we have to teach, we do not know. So, and the knowledge also is not current. The assessment, there is no guidance, there are no standards, no competency, no formative, because even the internal assessment has been wrongly used. Internal assessment is something to be used for formative, but we are using it for summative. Self-evaluation and peer review. So what happens is, those students who are good enough, they sail through, but others will have to stumble through. Course design is not there. There is no integration, time bound, modules are not there, choices are not there. You can't recover anything. If you have appeared for one exam, you can't appear and improve yourself. Leadership is not there. Research is not there. Course evaluation is not there. The entire course is never evaluated only. Where are we going? Critical thinking, professionalism, all these things are not part of it. In the preclinical, what happens is that we are using typodons and we are using your micromotors, which doesn't simulate the normal condition of the clinic. So self-evaluation is not done, and the most junior staff is always there. Whereas when you are trying to build the foundation of a student, the most senior person should be there, but that never happens. Assessment, single mode, there is no summative, or depth of knowledge is not there. Must know, nice to know, and good to know should be there, but it is not there, and only it is recall based. You have multiple assessment, like you have internal assessment, but continuous assessment which is required today is not there, and competency also is not there. So what needs to change? Let us see what can be done at the UG level. Now the DCI syllabus at the UG level is a lot stricter and more detailed. So lots of changes cannot be brought about, but still we can do a lot of changes with it. First thing what we have to realize, that if we have to use the flipped classroom, we have to use problem based learning, we need time, and time is of the essence, because every time the staff member will say, how will I cover the topic? But they forget that you don't need to cover the topic. You need to let the student discover the topic. Right? You just make them interested in the topic. So review of the syllabus and installing a curriculum, what is needed. So limit learning to only epidemiology and what is the existing practice for the UG level, right? Learning only what is to be recognized as a spare, and the student UG should know, okay, this is the thing which I can handle. Otherwise, I will have to call an expert. So, and flipped classroom should be utilized so that we can gain more time from the lecture. So things like pemphigus, herpangina, surgeries, both in endo as well as in oral surgery, cast partial, which not much people are using it. These things could be reduced. It can be only in the DD rather than asking full questions on pemphigus. So, clinical protocol should be that the UG should be able to start a treatment, and if they find that within 2 days there is no change, immediately should be calling it. So that kind of protocol should be built, and the UG level, it should be the entire syllabus could be limited to epidemiology. Didactic lecture should be taken online so that we have more time during the college hours to do a lot of other things like flipped classroom and PG. Competency based should be there, which is not there. So searching for literature is what we need to do, rather than students having to remember everything. They should within 5 or 10 minutes search on PubMed and give you the results if you ask a question to them. That I have already in the last lecture I have already talked how it can be done. It should be checklist based, and that checklist should also be given to the student, so they know what to do. Because they know what to do, and because there is self evaluation which is being taught, then the number of repeats which will be less, and that is why your course will become we can finish in 1 month. You don't have to give them 25 cavities. 5 good quality based fillings, if you are asking them to do, that should be good enough. Now there should be transition from teaching to learning, and that is why all these things which I have already talked about should be incorporated so that our teaching is better. Ergonomics should start from your preclinical. Ergonomics is something which will harm our body if we don't practice the right method in which we have to. So at the preclinical level only, so that lifelong the problem will not be there for the doctor. So that habits which are there should be inculcated at that particular level. Now, this is as far as your UG curriculum. What can be done in the PG curriculum? What is the stream? Now, dental school need to first of all teach what is how to learn, and second, there should be closed loop learning. Open loop learning is there is an input, there is a process, and there is an output. Whereas in closed loop, you will have in the closed loop, you have input, you have process, you have output. That output is then monitored, that improvement is done, again then the process is there, and then output is there. So you need to keep on changing on a continuous basis to reevaluate what is to be done. Function of the objectives should be set for content, for the context, any activities which you do, and whatever activities for the learners which you have to do. For each and every domain which is there, your cognitive domain, psychomotor, and adaptive domain, you need to have a set of objectives which is there, which will stimulate the learning process. The knowledge, understanding, and that thing, everything and the interactions which are there Everything should have some objective. It is the objectives which will drive us, and that is why we will be able to have enough time on our hand. So, what is the structure which we can have as far as PG is concerned? Now, PG, you should remember that the DCA has not given any specification. So, you can introduce semester based, a modular kind of system. Internal assessment, which is formative based. At present, there is no internal assessment. We could have a formative type. Competency based, cumulative grade point average, evaluation in the form of portfolio, learning management software could be utilized, and portability could be introduced. Now, what is semester based? Now, again, semester based was wrongly introduced for us. What we did was 3 subjects in one semester, 4 subjects in one semester. That is not the way semester is built up. Semester means it takes you from the simple to the complex, from the whole to the part, analysis to synthesis, empirical to rational. Slowly, the thing is raised. Depth of knowledge is considered, psychomotor skills are considered, communication or affective domain is considered. That is taken from the lower level to the higher level as you go from one module to another. A set of modules will create a semester, and that set of semesters will create the entire course. That is how things should be. But unfortunately, it is not done that way. So, what we need is modules. A modular system should be there. There should be specific learning objective for each module. Each module should be a concept. You are trying to teach one particular concept in that one particular module. From the simple to complex, didactic, and you should use all learning based methods. Didactic can be used for some part. Skill specification should be there. Communication skill specification, psychomotor skills, and ethical performance all should be there. And that is why integrated clinics something which should be required. So set of modules will create one semester. Okay. Now we talk about semester, and we talk about being from simple to advanced. But what exactly is this? I'll give you an example of conservative dentistry. So first module will be caries disease characteristic. So first we'll have the topic as epidemiology. So in cognitive definition of caries and what is caries, psychomotor detection, and in affective telling the patient that he has got caries and all, that should be there. Then the incidence and prevalence of caries will be there. So I explain the definitions of incidence and prevalence, how incidence is changing, conduct a survey, that is the psychomotor, and what is the importance of caries, and you tell the patient. Then the risk assessment will come in. They explain risk assessment, what is the procedure, what are the components, how do you perform the risk assessment. So, and tell the patient why he is at a high risk. Caries effects which are there, and caries pathophysiology. So what you are doing is that you are telling the concept of caries as a disease process and how it is present in the entire, and there are certain risk factors which are there which results in caries. That is the first concept which you give to the student in module 1. Now what happens in module 2? First we talk about is initial caries, and this particular stages are the reversible stage. So you have the module 1 where the caries is explained. Second, you say that there is a stage where it could be reversible. So caries initiation, loss of surface gloss, white spot lesion, brown spot lesion. Then how to examine the caries, how you will detection, how you will put separators and separate the teeth and look at the interdental area. Why is it reversible? You explain the pathophysiology of why is it what happens to the calcium ion, what happens to the phosphate ion, what happens to the hydroxyl ion, how that interchange takes place with the saliva. All those things are there. And then how to create that reversible nature by giving fluoride gel application, Fisher sealant, You can instruct the patient how to do it at home. Community fluoridation will be. The third module would be where cavitation takes place. So it is an irreversible change. So it is early stage enamel caries which is taking place, where you'll be able to have a catch if you have to probe that particular area, and then how you will treat that initial layer. Then you go for the next level where it is at the D junction. Next, when it is at a half of dentine, when it is very close to the pulp. So all this step by step modules, and in semester you take the students from the most initial stage to how complexity develops and how treatment will become more and more complex. That you have to teach. So this is how your modules will be there. So basic student will have presented basic knowledge, learning stimulation and everything. Practicals also according to Miller's concept. First they observe, then they imitate, and they perform on their own. The observation you can use flip demo presentation, imitation on simulators, and performing will be done in the clinics. Integrated clinics are very important in such cases because we need to go for holistic approach. Now, when you are going for a holistic approach, when we talk about holistic, it means that all the subjects, that is perio, conservative, prosthetics, everything comes together. It is multidisciplinary. Teachers from all the disciplines will come in that particular clinic, and the the students will learn patient management, not just doing filling, just doing scaling, or just taking an impression for partial denture or complete denture. That is not, we are trying to make them do patient management. Clinical environment should be there, and individual people with a clinical setup should be there. Now, the DCI can go really beyond this also. It can start the clinics right from first year. So according to the modules which are there, even at UG level, according to the modules which are there, the clinics also start doing that. So there is a correlation between what is being taught theoretically and what is going to be there in practical output of that. Risk assessment and epidemiology, which is not taken into consideration, will be taken into consideration, and that is the main crux on which the entire your teaching is based on. Preventive measurement like fissurotomy, sealant, fluoride, assisting the seniors, all these things will be in module 1, and that can be then going forward to other modules. Internal assessment, you will have a set of internal assessment which are done. End of module also there will be a test. At the end of the module, if you are getting enough marks, then you go to the next module. Otherwise, you have to repeat that module and improve your standard and then go to the next. This way, the standard of all the students will be raised to at least the base minimum. Formative evaluation should be done so that students get a chance for repeating themselves, improving themselves. Multiple tests should be incorporated for continuous like online test, anytime, anywhere test, open book test. Then you can have a home assignment, minor research work. You can partner them in meta-analysis, systemic review. You can partner them. Protocol partnering should be there. Table clinics could be utilized. The choice will be left to the student which examination pattern he wants. Only you will have to give weightages to that. Now, when you have continuous evaluation, there should be 360-degree evaluation, competency assessment, portfolio based, and cumulative grade point average should be there. So, if the choice is given to the student, it could be either 1 research and 2 home assignment, 1 research, 2. So, any of these combinations can be done, and students will take any of these combinations. These combinations can be changed according to your perspective. But what is important is that you give the choice to the student and see to it that they do in an easy manner. The learning or whatever examination tension should not be there. The online test also you can go from recall based to interpretive to problem solving. You can have a case, you can show the different photographs, then you ask multiple choice questions and you ask the patient. First, you will ask for recall, then you go for interpretive, and then you go to problem solving. You can also do it at different levels. First, recall level, once they pass, then you can say you have passed level 1, go to level 2. Level 2 will be interpretive, and level 3 will be problem solving. That can be done according to that. What is competency based? We talk about competency based, but what is that? The main domains for competency are critical thinking, professionalism, communication interskills, health promotion, practice management, patient care, assessment, diagnosis, treatment planning, and maintenance of good oral health. Now, when you are if you break up the critical thinking, it will break up into evaluate, integrate emerging trends in healthcare as appropriate, utilize critical thinking, problem solving, and then evaluate and integrate the best research outcomes. In professionalism, you'll have apply ethical and legal standards in the provision of dental care and practice one scope depending on what is the skill one has developed. Now, this is competence. Now, this basic thing can be broken down into specific objectives, and that specific objective will become your. For example, I can break this professionalism into respect all with dignity, prepare for clinical experience, and all these things. Now, one of the things is maintain patient confidence. Now, how do you evaluate that he has maintained patient confidence? Now, when the student refers the patient for, say, a radiological survey or a radiological scan, then whether he writes the patient name or not, that is important. He should send it only by the ID of the patient. Similarly, for lab investigation or whatever, whenever he does any referral or to the different department, it should be done only with the patient ID. If he's done that, that means he has attained the professionalism in that respect. So you give marks on a 5-point liter scale and then you give it to them. But all this should be done with a checklist to be there. So what you need is, first is the domain. Domains is broken down into different parts. The different parts is then broken down into small objectives, and that objectives are checked according to different checklists. Now, for example, and you have to include 360-degree evaluation also. For example, the first part of your case history taking, if you have to do, the marking should be done, the assessment should be done by the staff, by his own, he should do a self-assessment. Because we are tackling forehand dentistry, that means there is a one person who is also observing him, so he should evaluate, and the patient evaluation also to be done. So all the stakeholders which are there are giving the evaluation. Of course, there has to be weightage. The staff will have 60%, self-assessment will be 25%, peer assessment could be 5%, and patient evaluation could be 10%. That way, evaluation should be done. Marks should be given out of 5, and that will go into cumulative rate point of view. As I said, we need to have a checklist. And checklist also, there is certain process which is going on. For example, I have, for a radiograph, I have done this checklist. Now, B plus is the standard level of passing, where angulations, tooth centering, and no artifacts, that is the technique of the taking of the radiograph is perfect. But there might be some problem with the processing. Now, below that, B minus, C, what is there, are all about wrong angulations or wrong techniques and wrong processing. Now, I have not given much importance to processing purely because probably most of them will be using digital means, and probably processing is not required. And even if they are using processing, they will teach somebody assistant will be taught how to go and process. So he himself is not going to do it. So I don't want to give much importance there. Then A minus, where everything is correct, even processing is correct, but he is not able to answer to questions. A will be something where he is able to answer question, but that answering a question is only about the technique, but not about the interpretation. And A plus is something where he gives, he's been able to give answers to everything. So this is why grading is done. And these grades are utilized for cumulative grade point average, which brings us to cumulative grade point average, how it can be incorporated. Competency should be converted into grades, grades of all activities which is done. For example, suppose he is doing a cavity preparation. The sequence of birds which he uses, is that correct? The depth which he is going, is that correct? Is the isthmus correct? Is the angulations of the walls correct? Is any bevel given at the Cairo surface is there? All these are different points, specific objectives which are there, which needs to be graded. And that is what competency is all about. That is what competency is. So academic and research field, cultural, everything is there. So you need to give competencies on hourly basis, daily basis, weekly basis, modular basis, semester based, and all the semesters together which you do. If you are only utilizing one semester, then cumulative grade point average. If all the semester, it is called as overall CGPA. Then you have to give weighted and non-weighted. As you know, we have said that student will decide on what examination he wants. So he chooses the difficulty level. So if the student goes for higher difficulty, then he should get added weighted grade point average. So that corrections we need to do. What are the importance of cumulative grade point? Ranking can be done. Continuous assessment can be done. If suppose he applies for scholarship funding, this grade point average will be the means by which it can be done. Future post-graduation or master's, PhD, everywhere. Even if he has to join for cultural or sports, unless he has got some cumulative grade point average, basic one, he is not allowed to go for cultural and sports. That is how we go about it. Now, all these competencies are being recorded in the form of what is called as a CPA record. So, what the student does, how he is performing, how much knowledge he has got, what is the depth of knowledge he has got, what he has been able to demonstrate, and all the three domains which are there, that he will build in. So, what you do is first you finalize how to convert the grade into scores, how to the marks into percentages, percentages into grade. So all this is done first. Then for every lecture, you at the end of the lecture you give 5 multiple choice questions. They answer those multiple choice questions, and according to how many they have got, you give the mark after. You are not only interested in getting their attendance, you are also wanting to find out if they are mentally present in the classroom also. And these multiple choice questions will help you. Then you enter all his marks according to every hour, because community grade point average is calculated according to the credit hours. And if there is an 8-hour college, that means 8 credit hours per day. And for every hour, you have to give marks for that. Now, what lectures, what seminars, what journal. Now, this is the CPA card for PG. I have also done it for the UG, but I am not going to present there because of the time cuts. So, case presentation, CPC, where how much lectures he has taken. So, you get a cumulative grade. You record everything for both theory as well as. Similarly, you add up everything for yearly attribute, both for theory and practical, and you have this interchange of marks, grade, and the points which is corrected. Then you have the entire work schedule of the entire year. That is taken into consideration. Research what he has done, and as you can see, as the research complexity increases, the marks which are given also are increases. So in vivo, in vitro, survey is done or whether a original research work is done, you get higher mark. What EPD evidence-based work he has done? Has he formulated questions? Electronic search has been done. Critical appraisal has been done. So all this will again. Then cultural and sport activities, depending on whether it is at college level or whether it is national level, that grading is done. Then academic activities like paper presentation, poster presentation, table clinics, papers published, everything will get graded and he will get the approval. And then you start everything in a on a yearly basis, the consolidated grade for every headings which is there. Then you give a weighted grade for them, correcting the difficulty part. And then what he achieved is the cumulative grade of all these different. So overall development of the student is being calculated. Now everything can be recorded in a folded card like this, and the student can keep it in his pocket. So he also knows how progress is being made for his work. Next thing which comes in is portability. Now portability comes from knowledge management, knowledge transfer, and web-based training. So there are two parts in it: the learning module, which is one, and then there is something called a physical transfer. So portability in learning model and portability in physical transfer. Now a learning module which is there is basically required because we want students not to waste time in traveling. So it goes for web-based. We want them to do it learning at their own place, which is comfortable rather than the claustrophobia of a classroom or something of that sort, at their own pace. And since it is web-based, there is collaborative learning which takes place. So that is why you need portability. Now, if a learning module is there, then you need to have what is called as adaptive learning. Adaptive learning is based on intelligent tutoring system. Now, student has got some base knowledge. So when you have the next presentation on the web, it should be at higher level than what he has already got. And that is managed by the ITS system. So you are taking the students from the simplest to the most complex. Interconnectivity with the virtual classroom and the learning management software should be there. A learning management software is most important for us because personal learner, course catalog, database of the students, and because when they enter everything, written communication, vocabulary, grammar, syntax, everything improves of the students, and that is why it is most important. Now Moodle is available free of charge, and you can use that, but it is available only for 25 participants. So if your institute doesn't have that, you use a learning module for your department, which is for 25 is good enough for us. So intra-institute can be done across. So if these kind of web-based tutorials or webinars or presentations are there on the web, even if the student is in the north and and somebody in the south has given his lecture, that person can also attend and get credits for that. So overall learning increases, which brings us to physical transfer. Now physical transfer, why is it required is because you need modular structure. Transfer can be done at the end of the module. Suppose, for example, the parents of that particular student transfers. So if it is modular based, and if the modules are going on simultaneously at every place, then the student can get transferred. And probably this is going to come out in the new education policy. So there is no loss for the student. It is similar to the CBSE. CBSE also transferability or portability is there. So and second thing which the education policy is that there should be a diploma in computing. If suppose somebody leaves postgraduate middle, now this can only be possible if it is modular. Now the examples which I have given you of conservative, if the patient has done the first module, we can say that the skills he has achieved is of field survey and research. So he can be a research assistant for some field survey. If he has done the module 2 also, then apart from the surveys, he also knows how to do preventive questions. So he can be utilized for community-based approach which we need to do. So with each module, his capacity of work will increase, and that way his diploma will have some meaning. Which brings us to the portfolio. Now, portfolio will always give all the records. There will have to be videos, there will have to be photographs for each and every step which he does. And that portfolio will actually tell us how much proficiency he has developed, how many competencies has he mastered. All that can be done if you have the portfolio. So proficiency is there, his oral healthcare management, whether he can be a specialist or not, that can be evaluated. Whether he is innovative, whether he is and whether he is a team player and team leader, that also will be checked. Competency achievement is the greatest thing which will happen if there is a portfolio. Indicate performance is individual, and all the three domains, how he has progressed from the basics to the complex, that will be recorded in the portfolio. Which brings us to the next part, which is the research with the PG student. Now, I have already tackled the rest of the part except for translational research. So, I will take translational research now. Translation comparative effectiveness research, the CER which is there, is something which we need to do today. Evidence should be there of which is the best system, whether it is a material, whether it is an equipment, or whether it is a process, or whether it is some software. So, which are the best softwares, or so comparative study we need to do, because we have to choose which is the best out of that, so that the industry, policy makers, everybody gets informed which is the best. Now, traditionally, our model of teaching is a biomedicine model. So you have psychiatry, anatomy, immunology, cardiology, dentistry. That is how it is divided. But what we are looking at is convergent healthcare. So the mind and the body, how it is linked. The mouth and the rest of the body, how it is linked. How different systems like allopathic, Ayurvedic, or Korean medicine, or something of that sort, how it can be mixed. How can a new model be created by mixing all these different methodology of medicine? That can be done, and a new product can be created by us, which is the part of translational research. The steps in translation is first you in your lab create a research, you create a product, whichever it is there. Then you do clinical trials. Then you translate it to the community, evaluate how well it is working in the community. If it needs improvement, go back to the lab, improve that, and then come back to community based. This is how translation works. To give you an example, let us say the periodontal department has created a new toothpaste. It has the allopathic method also it has done, and some Ayurvedic ingredient also is there in that. So they developed a product which is your toothpaste. Then you do clinical trials of the toothpaste. Now these clinical trials, once it is completed, you go to the village. So you take the help of village industry, the Khadi Gram Udyog, or the micro small scale industry, and transfer that methodology of creating that toothpaste to somebody in the village who will be able to create toothpaste right in the village itself. So it will be cheaper, and it will be available to everyone. Then evaluation of that is done, how it reduces caries and failure, and if any improvement is done, it is done, and then retraining of that person is done. What have you achieved? Well, we have got, you have developed a village industry, you have given youth empowerment, technology transfer is there, and Atmanirbharta can be practiced by us as the field of dentistry. So this is how translation thing works. Which brings us to the technology. So there are various different technologies. Let us take them one by one. The first is artificial intelligence. Now, artificial intelligence has two different parts: data and data visualization. And data is not a simple data which we can do it on our computer. Data is something where the number of variables are so large that we cannot compute them on our laptops, but we need something called as artificial intelligence to do that for us. So aggregation of all this big data is utilized to create precision in our oral healthcare delivery. Data streams and aggregates have created a warehouses and data repository is created. From this data repository, the artificial intelligence part of it does predictive analysis and knowledge and discovery of how it can be applied to oral healthcare. It also includes how oral health care can be influenced by social media. And that is why it needs big data collection and artificial intelligence, because there are so many variables which are being used. So data mining, data analysis, biomedical informatics, and patterns, and for all this you need artificial intelligence. The augmented reality part is of data visualization. If you have artificial intelligence and if you feed that CT or MRI data into that, then you can create a hologram, and that hologram teach you everything about basic anatomy. So anatomy, anatomic orientation. Today we are learning only surgical anatomy, but neurophysiological, vascular anatomy, everything can be learned from this data. Neighboring structure and its relation. For example, suppose when we are teaching them TM joint, we are focusing on the TM joint. We don't say how it affects the TM joint of the opposite side, how it affects the muscles of that side, how it affects the chewing ability of that particular person. That is not taken into consideration. Whereas when you do this, you are looking at the whole body, and that is why your understanding also is better. So relation with the other system, local system, and body important. So if you have augmented reality about the face, you can go depth. You can from the skin, you can go right up to the bone. Now you have those cubes surrounding that. The cubes are used to expand it. Suppose if you want to enlarge it, you can enlarge, and that arrow marks which are there are to tilt it if you want to tilt it. Now, at every stage of this, if you want to get it 3D printed, it can be done. So, 3D printing and artificial intelligence, when it joins together, the learning becomes very important. We can learn what changes are being done at every level which is there, and you can see them. It is not necessary for you to interpret the radiograph. The radiograph will only give you probably bones and soft tissues if it is MRI. Both CT and MRI you cannot see together. Whereas here everything is together, and you can learn that. That's why you can learn better. The entire system, body system, can be done. If you are utilizing it for your cavity preparation, it can give you the exact measurement. What is the isthmus? How much is the isthmus? What is the depth of the cavity? All that information is there. So your cavity preparation also becomes superior if you are using artificial intelligence and augmented reality. Entire smart designing can be done with augmented reality and artificial intelligence. So if you have the data, you can feed it to the artificial intelligence. Once that data is accumulated using HoloLens, you can do that. The entire replacement of the teeth can be done with the chewing movements of the patient, so that occlusal interference and everything also can be done. Shade matching can also be done according to the face of the patient, and that is how smile design can be done. There are various applications, and all these applications which I am showing you are something which has already been done. Predictions as far as diagnosis, your whatever image is there, CT, MRI, or X-rays, predictions can be done. interpretation can be done. Precision in oral surgery, there can be a simulation of the leaf-foot fracture and can be presented onto the patient's superimposed, and then the patient will know exactly where incision to be taken and how to approach that fracture. Location of analysis, like in orthodontic cephalometric, the entire cephalometry can be done by artificial intelligence. Real-time imagery will be there. So during the operation, you are looking at CT scan, MRI scan, everything being projected inside, and you are looking at 3D visualization. Education, creating learning objectives can be done with them. Superimposition wherever distraction is being done, so where it is to be placed. Simplification of the implant surgery, because you can create a template for implant and exact positioning of that can be done. Stereoscopic visualization can be done. Placement of brackets or fillings and everything can be precise. You plan to place a bracket on the cast, but when you place it in it can change a little. The little change will cause unnecessary forces and may cause some movement which you don't desire. Teeth replacement, like smile designing, skill development is can be possible because it is haptic guidance is there. Cavity measurements can be there, and telecommunication can be there. Surgery can be done at one place, but that projections can be guided by somebody sitting outside. Artificial intelligence, big data, and deep learning are part of machine learning, and it is the machine learning which gives you the application in different limbs. That brings us to the one of the most important part, which is coding. Uh, Mr. Sushant Rajput was one of the most intelligent Bollywood personnel. He was on artificial intelligence, deep learning, and coding. Coding was his specialty, and he uses neural algorithms. He created an app for vocational guiding of students at the age of 8 and 10. So, at the age of 8 and 10, a student will know which branch he is to take. But what is it important in dentistry? How we can use coding in dentistry? Now, you know that we have to practice evidence based, right? That is how, because it is also required for the best treatment to be made, best decision to be made. But unfortunately, today, whatever data is got is only of the material. Which material is better? Silver is better, amalgam is better, composite is better, or a combination of GI and composite is better. That testing is all there, all data is there. You can use evidence based. But a clinical case, you have got nothing for that. So it doesn't give you any guidance of how to use it. For complex treatment planning, large cavities which are there, where multiple variables are there, creating evidence becomes a difficulty. For example, this particular carious cavity which is there, you can do exceptional work like this, but you don't know whether it will last or not. So, what we need to do is go for caries risk assessment. What is the existing caries? What is the previous caries? What is the root caries which is there? How much fluoride exposure is there? What are the diet factors are there? Now, each of these are given numerical values. The assessed risk is transferred into a numerical value. Now, when you have this numerical data, you have measurement. Then you add biting force, thin supported walls, occlusion, the chewing habit, what is the pH and all. So by assigning all this, you are getting a different code. It is similar to what ICD codes are there. So this code characteristic tabulation and pattern recognition creates the coding. And now once that particular cavity has been given a particular code, you collect all the cases where the similar coding is done and do research on there, which material, which technique, which process should be utilized for treatment, and that will create the evidence. So the evidence of future will have to come from coding, and that is why we need to learn coding. and it is not very difficult also. If you apply your mind, it can be done. Which brings us to 3D printing. You can 3D print. You can make a stent for your implants. You can study the model how they move. For complex cases, you can have different in different colors. You can have, so you know how dense invaginators has taken place. You can produce the crown, the dentine, and the cementum, the root canal separately, and the whole tooth also. So that particular tooth can be used for preclinical work also, for patient, for doing root canal treatment. You can have these models from which we can plan how you will put the loop around the premolar, how will you pull the, how do you do marsupialization, and how you will pull that premolar out. That can be done. If you want to, if you are finding it difficult to go with a straight line access, a stent can be prepared for that. The importance of 3D printing is that the bone, muscles, the glands, skin, everything can be reproduced. Everything can be made. Replacement of the ear and the eye can be done. Implant along with the, if there is a fracture or deficiency in the mandible can be done. If there is a tumor, we can do it in different this thing. So students can learn how perforations takes place, how the tumor comes out of the bone, how expansion of the bone takes place. Any part of the human body can be done. You can find intricate details of each and every part of that. You can have these models for learning because what you see on the radiograph doesn't mean that it is entirely filled with tumor material. There are gaps which are there, which is filled with fluid. That is also there. In forensic, you can build up the face of the person for identification. Ant-mortem and post-mortem models can be done. Even the fetus can be created by 3D printing, and you can do age estimation of the fetus also, which brings us to lasers. Now, soft tissue lasers, everybody is doing in every college, it is present. So, I will not touch upon that. Today, what is important is hard tissue laser. Today, the problem with COVID is that there is an aerosol which is taking place, and aerosol is creating a fear among us. So that is why instead of creating aerosol, we need to go for hard tissue laser. All your cavity preparation, crown cutting, and everything could be done with an appropriate laser. So that development needs to be done, and the dentistry should get involved in that. And another factor which is there, which is done, is the hologram. The study of holograms of the face, of the teeth, intricate details of the teeth can all be seen with a hologram, and that is why we are creating hologram with lasers. Will also is an important aspect. Which brings me to the simulators. Now, normally what we are doing is typodont using micromotor. That does not simulate the patient in the clinical setting, and that is why it is not as good. Simple simulators are those where drainage is also possible. So you can use air rotor. You can use your what you call separators. We can utilize, and the tooth could be separated. All this can be done on your simple simulator. But what about advanced? The advanced simulators uses artificial intelligence and augmented reality. So whatever cavity preparation you are doing is being projected. If you have used a particular burr, then the software has that repository. You can also choose that burr for the handpiece which is seen in the computer. So there is a matching between what you are doing and what is being shown on the screen. So the entire cavity preparation can be followed on the screen for us. The face can be also scanned, and that can be utilized so that you get the feeling of a real person being there. The fingers can have sensor, and it will track the movements of the finger. That will tell us how the person has utilized his resting position, what kind of rest he has taken, how much is the movement of the control, the movement of the handpiece is there, all that. All this can be converted into competency. The depth of the cavity, because you can see the mesiolingual, mesiodistal part, buccolingual part, the superior part, everything can be seen of the cavity. So all measurements can be done. So it tells you the competency which the student has developed at every stage of that cavity preparation. And everything can be converted into cumulative grade point of view. Another important part is that whatever the student is doing is then transferred onto the in a central monitor like a CCTV, and the staff member can see in that. And if they find that somebody is going wrong somewhere, immediately they can go and they can improve. Ergonomics can also be taught by this particular method. Root canal, if it is there, locating the canal which is there. Every measurement which is there can be possible on that. But plus the most important thing is that it has got its own repository. So it knows what is an ideal cavity cutting, and it will tell you, okay, this is the ideal cavity and this is what you have achieved. So what is the difference which is there? So there is a continuous kind of guidance which is available to the student. So guiding preparation, instant feedback, 3D orientation, measurements, competencies will be assessed, and staff will be able to monitor and grade the student much more better. You can take radiographs also. Radiographs will also come on this. There is a game-like feeling, and that is why students like it more. It can be repeated n number of times. Ergonomics can be done, and it is very simple because haptic technology is used in the artificial intelligence, and that is why it makes it easy. Which brings us to T-scan. T-scan is an entire totally different subject altogether, and we will need to take a separate. But only thing is I'm mentioning is that should be compulsorily used in dentistry. Online learning assessment, I have already been talking for the last three of my presentations. So I will not go into details. Only thing is to stress is that this should be utilized. And the way it should be utilized can be taken as a different webinar altogether. Which brings us to the curricular changes if the DCI would like to change. What we need is vertical integration. At present, there is no integration at all in dentistry. So we take material science in the first year, and we are using that material science in the fourth year. There is no linkage. So instead of that, if you have a modular system, then the materials and where it is utilized. For example, you are teaching them impression taking, then the materials which are used there can be done there. Semester modular based system can be both used in the UG and the PG. Evidence based process could be included. Student should not be to remember. You don't judge the student by how much he can remember. Rather, how much he can apply that. That is more important. We have to modify even our examination and everything where it should not be on recall base. UG and clinics should be from first year itself, and all subjects should be introduced from first year, so that the student gets an overall view of dentistry right from first year. Medical subjects, there will be dental faculty inputs also. For example, person is being taught myocardial infarction in general medicine, but he should not. He is not necessary for him to learn myocardial infarction. What he needs to do is, if in the chair, if the person is going into myocardial infection, what are the signs and symptoms? And if the patient has got myocardial infection in the past, how is, with the kind of medicines he is being given, how dental treatment will be modified, that needs to be taught. And that is why dental input should be, and continuous assessment should be there. So if you need dentistry to fly, then probably even the DCL will have to pull up their stocks. As Abraham Lincoln said, the best way to predict the future is to create it. and that is what we should do. Now, if this is your expression at the end of the lecture, then you need to wake up. You need to get out of your comfort zone and create the changes which you are all capable of doing it. But inertia is not allowing you to do. Thank you very much for your patient listening. Thank you, hashtag and government data. And I will now